with any financial disclosures. My past case is about a 28-5 baby presented with blurred vision in the right eye since 5 days. And she had history of fever with skin rashes 1 year back. It was diagnosed to have a Kikuchi's disease. And she had associated retinal vasculitis for which she was treated with systemic steroids elsewhere. Subsequently, she was treated with immunosuppressives using methotrexate followed by azathioprine. And along the course, she had multiple superadded skin infections treated with multiple antibiotics at presentation. She was on treatment with tablets Sazo, leflunomide and aceclofenac. On examination, the patient had multiple papulopustular eruptions on the face and extremities and the skin. This is at the time of presentation to us. This was 1 year back when the patient had multiple skin lesions and subretinal lymph node biopsy diagnosed to have Kikuchi's disease. And in addition to that, she had hand deformities, the joint swelling and erosive arthritis. Ophthalmic examination, visual acuity in the right eye was 6.9, left eye was 6.6, intraocular pressure was within normal limits. Anterior segment examination revealed flare and traces of cells. There was a broken posterior synechiae with pigment deposits on the anterior lens capsule. Fundus examination, she had vitritis and vitreous 1+, because she underwent a fundus fluorescent angiography which revealed diffuse perivascular leak in both eyes. The treating immunologist told us whenever they step up this, either the immunosuppressive or the steroid skin lesions worsening. So he specifically told us not to put her on systemic steroids, so we treated her with periapical transdermal acetonide injection for both eyes. She received 2 doses and ocular symptoms have improved. And 3 months later, she presented with worsening of inflammation both systemically as well as in the eye. We can see the papulopustular eruptions, which is more of pigmented, in the extremities. This is also on the legs. In the legs, we can see the indurated lesions with pustular eruptions. The pus was pouring out in the legs. At this point of time, she had traces of hypopia in the right eye. Left eye, she had hypopia with non-granularis anterior uveitis. Fundus examination showed areas of retinal infiltrate as in the form of multifocal retinitis. Left eye vitreous haze was there. In view of cold hypopia, multifocal retinitis, associated skin lesions, we made the diagnosis of Behçet's disease at this point of time clinically. We ordered HLA-B5 came positive. And we insisted the hematologist to start her on cyclosporine because of the multiple superadded bacterial infections. He was a little bit hesitant initially, but we treated the patient with systemic steroids, cyclosporine with appropriate antibiotic cover. Within 2 weeks, we could see the resolved skin lesions in the extremities and also complete resolution of eye inflammation in both eyes. She was doing well with cyclosporine and systemic steroids. On 6/11/2013, she presented when she was on tapering dose of systemic steroids, that is alternative day regimen, along with cyclosporine, presented with decrease in vision in the left eye. She said had mild discomfort, maybe fever 2 days back. She was not paying importance to the history. On examination, visual acuity in the left eye was 6/18, intraocular pressure was normal, right eye examination was absolutely fine. The left eye revealed presence of hypopia with multifocal retinitis associated with hemorrhages, vitreous cells and hyperreflective pores on the inner retina. So we thought, having the known case of a Behçet's, there is a reactivation of Behçet's disease. And since she gave history of fever, we ordered for the complete hemogram. The total count was increased, that is 13,000. This could be maybe due to the long-term systemic steroid therapy. And we stepped up the systemic steroids to 60 mg. In view of fever, and we put her on additional empirical antibiotic therapy as well, and topical steroids and cycloplegic were continued. She comes back the next day. There was a worsening of inflammation in the left eye and also the appearance of new lesions in the right eye. So we did the AC tab to rule out any associated infective agents, and systemic antiviral also has been added. 3 days later, when we got the report, the PCR for the viral and the bacterial genome came negative. 4 days later, she comes back to us with pain and swelling, the infected boil kind of a picture in the chin. We did the culture. Culture and sensitivity showed Staphylococcus methicillin sensitive Staphylococcus aureus came positive, which was resistant to ciprofloxacin. We changed the antibiotic from ciprofloxacin to Novoclox, that is ampicillin with cloxacillin. Within 24 hours, the lesion started disappearing. This is after 48 hours, complete resolution of the inflammation was noted in this patient. But on FFA, we noticed the disc staining with diffuse capillaritis. The perivascular leak was seen in both eyes. Continued with systemic steroids and cyclosporine with antibiotic therapy. Coming to the discussion, TQTs or histiocytic necrotizing lymphadenitis is characterized by the presence of fever, lymphadenopathy and neutropenia. Diagnosis by the lymph node excision biopsy. The exact etiology is unknown. Could be autoimmune hypothesis where we have seen Kikuchi turning into an SLE, but however there are no reports Kikuchi turning into a Behçet's disease. The diagnosis of Behçet's is clinical based on the presence of characteristic ocular and systemic manifestations. An infectious etiology must be ruled out even in patients who are diagnosed have a case of Behçet's disease as seen in this patient. We'll move on to the next case. A 58-year female diagnosed have a viral retinitis and panuveitis not responding to the treatment with antiviral and systemic steroids referred to us for second opinion in July 2013. Examination of the right eye was normal. In the left eye, best corrected visual acuity was 260. Anterior segment examination showed the presence of circumciliary congestion and medium to large keratic precipitates associated with AC cells. Fundus examination of the right eye was normal. In the left eye, there is greatly media haze and mild hyperemia of the disc, and associated with this pallor is noted, and there is a sclerosed vessels with multiple areas of retinal opacification as characterized in the form of multifocal retinitis. The close follow-up of the image where you can see the sclerosed vessels with retinitis and two other lesions of retinitis. So this is a multifocal retinitis. We thought this is maybe a atypical form of toxas in the form of pyrrhus arteriolitis associated with retinitis. We got the investigations done and OCT showed the presence of ERM and hyperreflective echoes in the inner retinal layers and hyperreflective echo corresponding to the areas of arteriolitis, where we say the classical pyrrhus arteriolitis. And whenever the toxo lesions heal or during the thing, there is a characteristic ERM formation over the retinitis lesions. So when we got the investigations done, the IgG came positive. IgG was 500 international units per ml. We did the ACTAP, came negative for the viral genome, HSV, VZV and CMV. Toxoplasma B1 gene came positive, confirming the diagnosis of toxoplasmosis. We did a confocal microscopy for an academic interest, which showed central globular dendritic goes well with the toxoplasmic kind of a retinochoroiditis which we've seen it earlier in a study. So here the picture must have been altered, mainly because of the systemic steroid use without an appropriate antimicrobial therapy for toxoplasmosis. So when the patient presented to us as in the form of multifocal retinitis with pyrrhus arteriolitis. Coming to the toxoplasmosis management, systemic antitoxo treatment with sulfa, pyrimethamine, folinic acid to be started first, followed by systemic steroids. The same way, systemic steroids should be tapered first, followed by antimicrobial therapy. Topical steroids and cycloplegics have been used for associated anterior segment inflammation. So this particular patient received 2 weeks of systemic antitoxo and systemic steroids, but we did not find much improvement. So at this point of time, we are given additional intravitreal clindamycin with dexamethasone with 1 mg in 0.1 ml with 400 microgram of dexamethasone was given. Patients received 3 doses of injections, following which you could see the resolving retinitis in this patient. Coming to the discussion, so we presented 2 cases of multifocal retinitis. One had like cold hypopia with multifocal retinitis with a reasonably good visual acuity, secondary to autoimmune uveitis. Whereas the second one also had multifocal retinitis. Here the patient is symptomatic, associated with decrease in the visual acuity, and we could see the alterations in the retinal changes with decrease in visual. This case illustrates the possible consequence of systemic steroids in infection with toxoplasmosis. Clayton and Rush et al. Have reported similar cases, whereas Rush reported fulminant toxoplasmic retinochoroiditis following intravitreal triamcinolone acetonide in a case of idiopathic uveitis. The picture is similar to our case. So the classical therapy consisting of triple therapy where we use sulfa, pyrimethamine and systemic steroids. In immunocompromised individuals, preferable to avoid the systemic steroids and treat them with antitoxin drugs alone. Suppose if the patient is pregnant, spiramycin is the drug of choice. Whenever we see a retinitis, it's most commonly associated with infective uveitis. We need to rule out infective etiology before we consider an autoimmune. Atypical multifocal retinitis, in addition to serological testing, the molecular diagnostics help us to confirm the diagnosis. Systemic steroids should be started only after appropriate antimicrobial therapy. Intravitreal clindamycin can be used as an adjunct in addition to the systemic medications in a case of atypical multifocal toxoplasmic retinochoroiditis. So, take this opportunity to give your feedback. SMS to 92200 92200 regarding the feedback of this IC, and also we invite you for the annual meeting of the Uveitis Society of India. That's November 22nd and 23rd. It's going to be in Delhi. Dr. Shashir would like to say.